So I think the first thing to say is that there were quite a number of different areas that we looked at for our purpose. So that was probably one of the first key bits of this, but we've plumbed on what is probably a fairly common theme. So we've really tried to focus down to a relatively narrow question, but we felt it was important, and that was to develop a robust and specific HbA1c pathway with, in particular, a comprehensive assessment tool, targeted support for the patient. So actually trying to see if we could do something different to affect change. I've been very specific about that because we've had a high HbA1c pathway for a long time. It's just that the whole team felt that actually it wasn't effective enough. And what we're trying to do is concentrate on the group of patients who've got an HbA1c above 9% in order to improve their outcome. So what great will look like is if we've got at the end of this a very clear plan of how to manage our HbA1c pathway and actually successfully affect change. So I think that comes from the fact that we felt we had a cohort of patients who sit in the high group and they don't shift. Next slide, please.
Should have the next slide now, if that's right.
So this is our full team. So I'd like to thank everybody for this. Has really been put up to say that we've had full participation from every member of the team, and you'll see why that's important in some of the slides along the way. Thank you everybody for contributing. We took that on board from the previous session, so everybody has contributed. Next slide, please. So our purpose, as I've already said, is to develop a high HbA1c pathway with an assessment tool. This stemmed from work that some of the members of the team had already done. We've got James, our data manager, has actually run a very comprehensive database independently of anything else. So because we don't have Twinkle, so we actually had some quite robust data in order to look at, and along with what we submit to the NPDA. And actually this was able to target our patient group reasonably precisely and identify a specific cohort of patients that we were concerned about. We're measuring our HbA1c values in those patients after 6 months from diagnosis, so beyond honeymoon, and also some of the evidence base out there from Ragnar Hannes's group in particular about actually targeting patients beyond 6 months. For obvious reasons, we're not concentrating on the newly diagnosed patients. Also, to look at, because a lot of our patients are on technology now, was time in target range and coefficients of variation. So not just HbA1c, but our main selecting criteria is an HbA1c above 9%. But it was also felt, so input from psychology and the nurses was that we really needed some kind of assessment of other things which were affecting this beyond just the insulin regime. So we've incorporated in our pathway some of the qualitative validated questionnaires, such as the PAID questionnaire, etc. So looking at other factors which might impact how they control their diabetes. So as I said, we're going to use HbA1c as our main criteria, but also look at some of these other areas. Next slide, please. So this is in real life, how we brainstormed it with spider diagram, etc., and using some of the tools that you've given us. It took 2 or 3 sessions for us to sort of start to thrash out actually how the pathway was going to look, and looking at what we did previously and working out why things weren't working. Next slide, please. So this one is probably difficult to see, is really just to show you what we were doing previously and what the proposed pathways to move to. So the obvious question is, we had something in place previously, and it was pretty robust, but it wasn't providing the outcomes that we wanted. So what's the difference? And I think this is where consistency comes into it, and I think this has been one of the effective tools of it. I don't know if Katie wants to comment on this, is that we really, as a team, talked about why the old pathway hadn't worked as well as we had wished. Having said that, it was quite good to celebrate actually, the number of patients that we had brought out of the high HbA1c clinic, because actually I think that was a revelation to us. As actually there were a number of people where the pathway had worked, but not as many as we had hoped for. And really the main message was that actually everybody was doing things slightly differently in the old pathway, and that there was no consistency. So really looking at the new pathway, we've spent another 2 or 3 sessions really just talking about what consistency means and what we're doing. So looking at the tools that we're going to do and how we're going to use them. So you can see that it's been simplified. It's very difficult to actually project this, but there's a specific arm here down this side to do with psychology assessment. So much more greater importance put on the validation tool. So on this side, there are some glycemic validation tools that we're going to use. So rather than just using our acumen and our experience in the clinic, we're actually going to assess the patients, going into the clinic, actually looking at the assessment tools and actually trying to work out what the problem actually is. Because sometimes we feel that actually the problem's not about adherence to the regimen. It's actually due to other factors, that they may be depressed, or I'm just picking that out, but a multitude of different reasons. So our improvements, we do feel that there's been a benefit in terms of improved team working. I think to some extent me and Katie have been quite challenging in those meetings, but deliberately so. Katie's done a really good job in being a disciplinarian in a polite way in our team meetings, but really working on consistency. And we've had input from members of the teams who've been a bit quieter. So I'd like to celebrate Hayley, our clinical support worker, who's now started chipping in, but also the psychologists and the dietitians having a greater voice rather than the likes of me droning on. And so we have come up with these sort of targeted checklists and come up with an initial plan. More recently, there's been a discussion about capacity. And I think it's not just COVID, it's really just a talk about what we're doing and actually, how we're actually going to be effective. So actually, we've decided on a much smaller pilot cohort to go for. I think initially we're talking about patients being seen for an hour slot each time, and only 4 patients within one clinic. So it's actually, quite resource intensive. And so we're going to run it as a pilot and actually see if we can affect change in order to learn lessons from that. Our actual cohort of patients that we could select is nearer, I think, is it 75 KT around the ones which fit into this category? Is that right? Can you remember?
Sorry, yeah, that's about right. But I think even more recently, when we've been kind of narrowing down the patients to be included in the pilot even further because of the capacity, and we talked about including patients over 6 months diagnosis but under 2 years, it was kind of significantly even much smaller than that. And it just goes back to what everybody's been saying recently about just starting really, really small. If we don't feel like we can take on such a big project, just really narrowing down kind of our starting point.
Yeah, I think we really wanted to see that what we developed is actually going to make a difference. And actually one of the key themes is actually using these systematic tools so that we all do the same thing. Otherwise, we'll never know whether it's because one person's more effective than another. So there have been, I think, as you get with all teams, some barriers. You know, the usual things with IT, but also more recently, it's been, you know, concerns about trust directives on particularly nursing. You know, where they're going to be deployed to. So again, restricting the size of the project and doing something manageable seemed like a sensible idea for us. So what are the most useful things that we've learned so far? I think top of the list is consistency. You know, everybody doing the same thing, working towards a shared goal. The fact that we've actually got some quite strong data to use and actually looking at that, so actually we can affect change, because I don't think, apart from the NPDA and how we looked at that, I don't think we were sort of routinely looking at our data in that sort of critical way. I don't think we're fully there yet, but actually this tool will help us to have more data to use in a more specific way. So I think that's been a benefit. And like I said, I think celebrating our achievements actually, and understanding that the nurses at high HbA1c clinic had a beneficial effect, but possibly not as much as we'd hoped. So actually, it can sometimes seem like a bit of a drudge with our patients, but you know, actually seeing the numbers, you get a greater appreciation of what you're actually doing. So I think we're a work in progress, but we can clearly see the benefits of the process, whilst we are a bit concerned about our capacity to deliver the full QI project, mainly because we want to do it properly. I think that's the other thing to say. I think our concern is that we've put a lot of effort into QI, and that the trust's response to COVID was going to stop us from doing that. Right. Is anything else you wanted to say, Katie, or other members of the team?